Now let's look a little bit more closely at clinical leadership. Clinical leadership applies to all clinicians, nurses, therapists, pharmacists, physicians, and others whose primary job is taking care of patients. We're going to focus first on non-physician clinicians and their ability to gain leadership skills. There have been many excuses for why there is a lack of leadership skills in healthcare in general, and in particular in clinicians. Some suggest a service design is inherently inefficient, and that healthcare services are especially inefficient as a result of the variability in the human condition, that focus on do no harm, perhaps rather than do no harm through adopting best practices, and also the pervasive nature of siloing that is emphasized by credentialing licensure. This view is almost a self-fulfilling prophecy. There are many examples of resultant issues from this excuse that a service industry such as healthcare lacks leadership by default. But one thing that is just starting to be addressed is the need for clinicians to work to the level of their credential or license. Because there is so much blame and intimidation, many nurses especially, and other allied health professionals as well, often do only what they are directly told to do and do not assume any responsibility for more, such as to recognize potential issues with their patients or to offer suggestions for improvement in workflow, let alone in clinical care. An example of this from not too long ago, based here in the Chicago area, was a lab tech who thought results of a blood test were very abnormal. But other than providing the results in the routine manner, did not alert a patient's nurse or doctor because of previous experiences suggesting such alerts were not wanted. Sadly, the situation resulted in the untimely death of the patient, actually a newborn. Issues such as these are not confined to the hospital environment. In physician offices, maybe not as critical, but many nurses are not permitted to document in the patient's record, for fear by physicians, of course, that the nurse will write the wrong thing that could potentially reduce revenue or lead to a lawsuit. Sticky notes are relied upon as communication tools, often unsuccessfully from a clinical perspective, but perhaps as a successful means to avoid confrontation. A second excuse for lack of leadership is that healthcare is more complex because of its triad governance structure. That is a governing structure including a governing body, board of directors type of thing, administration, and medical staff. Administration and medical staff are especially at odds with one another because administration is not qualified to make health decisions and medical staff have no explicit authority to make administrative decisions. Whichever physician brings in the most revenue, however, often wields implicit authority. Then there is a lot, as a third element, there is a lot of avoidant leadership in healthcare, which is especially prevalent among nurses. Nurse leaders are in a very tough position because once again there is a dual reporting situation where there is a nurse boss and a doctor boss that the floor nurses and others must take orders from, and which are not uncommonly conflicting. Nurse leaders are often overburdened by complaints. As a result, they use avoidant forms of leadership, perhaps to keep themselves from burning out. Avoidant leadership may mean affirming concerns but taking no action, avoiding listening to concerns to begin with, and being ambivalent in any response when pressed, or becoming hostile to the complainant to stifle and hence avoid receiving any further complaints. These scenarios are clearly not contributory to healthy environments. It often takes several rounds of executive dismissals as a result of a severely distressed financial picture to overturn such an environment. Even though leadership can be learned and turnaround is possible without complete upheaval. Now let's take a look a little bit more closely at physician leadership. Well, not to suggest that leadership issues in healthcare are all the fault of physicians. An article by Dr. Drummond entitled Physician Leadership Skills: Why Doctors Make Poor Leaders and What You, the Physicians, Can Do About It, is an especially thought-provoking article that offers concrete suggestions for improvement in 3 key areas this good doctor believes are game changers. The following discussion is an extraction of content from this article. A dysfunctional default physician leadership style, Dr. Drummond says, derives from the fact that medical training is almost exclusively focused on clinical skills, despite that physicians are expected immediately upon graduation to be a care team leader with never any basic leadership skills. Automatically, a dysfunctional leadership style is adopted that is based on giving orders, never giving anyone else on the team an opportunity to weigh in or offer suggestions. It's not really a team. Over time, the default command and control leadership style, Dr. Drummond says, turns your team into sheep. It's probably also likely that this same style is mimicked in all of the other clinical disciplines, even as others deeply resent these physician traits. But on to the matter at hand. What you can do differently is offered by Dr. Drummond as you, physicians, need to understand there are multiple areas of your practice where, in caps, you are not the expert. Start to use the whole team's expertise to address the problems you are facing. Another admonition: ask more questions and give fewer orders. When you work together to systematize and delegate, you won't feel like you are doing all the work yourself, and your team will feel honored and more involved. A better practice experience for you, your staff, and your patients will result. Second, no physician leadership training and a nonsensical business model is the second element identified by Dr. Drummond. Here he observes that physician leadership, facilitation, and the meetings required to coordinate the actions of a team are considered by physicians as necessary evils we would like someone else to address. Next, he targets the healthcare business model by offering the following scenario. Imagine the CEO of an automobile manufacturer who is simultaneously the only person who can put the doors on the cars in the assembly line correctly. The boss is the biggest bottleneck in the system. Who would design a business like that? The who, Dr. Drummond answers with the response, the world of medicine. Dr. Drummond further lists some basic leadership books to read. The last title sums up his message best, I think. What got you here won't get you there. That book is by Marshall Goldsmith if you want to check it out. Finally, we demonize managers and become part of the problem is the last element in the article, acknowledging that physicians as a group tend to see anyone in a management role as the enemy. Instead of bringing managers only problems and complaints that turn into hostile venting sessions where nothing gets accomplished, take responsibility to become part of the solution. The article concludes that any efforts doctors put into their own physician leadership development pays immediate dividends. I say this physician should be given kudos to have the guts to write this article. Wow. Okay, let's look a little bit more closely then at clinical leadership characteristic. In the article by Daly and others, The Importance of Clinical Leadership in the Hospital Setting, the case is made for hospitals, and it really could be made for all of healthcare, to focus on 8 elements that have been compiled by a survey of the relevant literature and that are believed to improve leadership to better address current challenges. These are described as situational, skill-driven, value-driven, collective, co-produced, exchange relationships, and boundary spanning. Let's look at these a little bit more closely. Leadership being situational, where what is referred to as microsystem issues must be diagnosed and treated. The term microsystem was used by Donald Berwick, who's the founder of the Institute for Healthcare Improvement and a former head of CMS, in his work Understanding High-Performing Clinical Microsystems. He defined clinical microsystem as the combination of a small team of people who work together on a regular basis or as needed to provide care, as well as the individual who receives that care, who also can be recognized as a discrete subpopulation of patients. A clinical microsystem has clinical and business aims, linked processes, a shared information environment, and produces services and care which can be measured as performance outcomes. These systems evolve over time and often embedded in larger systems and organizations. Again, this was before value-based care became the popular trend, but very much in alignment with our issues today. Leadership being skill-driven as the next element in the list has been discussed in this lecture already. Probably don't need any more. Leadership as vision-driven refers to having a strategic view and the ability to interpret that view into point-of-care delivery. Leadership as collective was seen consistently in the rankings by global organizational leaders, where leaders enable others to act, are advocates, and are approachable. Leadership enables co-production for the ability and the responsibility for all staff to lead, to be interdependent upon one another, and to be networked. Leadership promotes exchanged relationship, serving as a role model, motivator, and empowerer of others. Finally, leadership crosses all boundaries, spanning collegial, bureaucratic, and interdisciplinary boundaries, and linking across point-of-care microsystems, certainly intended to overcome those silos we've been seeing.